Hi everyone. Today we're discussing what to do when your first-line antiarrhythmic therapy, such as lidocaine, fails for a dog in ventricular tachycardia. This is a high-stakes situation that demands a clear step-by-step approach. But before we dive into treatment, let's quickly review the main diagnostic criteria for ventricular tachycardia. Although the diagnosis is usually straightforward in most canine cases, certain abnormal rhythms like supraventricular tachycardia with aberrancy or accelerated idioventricular rhythm can sometimes be confused with true ventricular tachycardia or V-TACH. Whenever you see a wide QRS complex tachycardia with complexes wider than 0.07 seconds in dogs or 0.04 seconds in cats without any associated P waves, and the ventricular rate is at least 160 to 180 beats per minute or greater, your first differential should be ventricular tachycardia. Each QRS complex is usually followed by a large T wave in the opposite direction. The presence of capture and fusion beats makes the diagnosis even more likely. A fusion beat happens when a ventricular impulse and a supraventricular impulse fire at the same time. The result is a QRS complex that looks like a mix. Not quite a normal sinus beat, not quite a ventricular beat, but something in between. A capture beat, on the other hand, occurs when a supraventricular impulse slips through the AV node during ventricular tachycardia and conducts normally through the ventricles, producing a single normal-looking beat in the middle of the tachycardia. V-TACH is considered non-sustained if it lasts less than 30 seconds and sustained if it persists longer. Non-sustained V-TACH is usually asymptomatic because of its short duration, while sustained V-TACH can quickly compromise perfusion. We also need to separate V-TACH from accelerated idioventricular rhythm, or AIVR. If the ventricular rate is faster than the normal idioventricular rhythm, which is about 30 to 40 beats per minute in dogs and 60 to 130 in cats, but it's still slower than V-TACH, that's AIVR. AIVR looks very similar, but the ventricular rate is slower, typically below 160 to 180 beats per minute in a dog. This cutoff is somewhat arbitrary and may vary depending on the clinician you talk to. So, the key difference between AIVR and V-TACH is the ventricular rate. AIVR almost never requires treatment, and that's the most important reason why it should be recognized. It usually resolves spontaneously without antiarrhythmic drugs in around 4 days or so. In emergency and critical care, the most common causes of AIVR are shock, systemic inflammation or sepsis, certain splenic or liver tumors, GGV, and other critical illnesses like polytrauma. The mechanism isn't fully understood, but it's thought to be similar to reperfusion arrhythmias seen in humans after heart attack. Chemicals mediators like reactive oxygen species and cytokines disrupt ion channels and contribute to the abnormal rhythm. All right, once you've confirmed that a patient has a wide complex tachycardia with a ventricular rate above 180 to 200 beats per minute, the next step is to assess cardiovascular stability. This should be based on at least 6 core perfusion parameters with optional adjuncts such as arterial blood pressure and plasma lactate levels. It is more common for patients to be hemodynamically unstable when the cause is ventricular tachycardia compared with wide complex tachycardia due to mimics such as accelerated idioventricular rhythm or SVT with aberrancy. That said, some dogs with ventricular tachycardia may still present as stable. When the canine patient is unstable due to ventricular tachycardia, intravenous antiarrhythmics, most commonly lidocaine, are strongly recommended. A slow intravenous bolus of lidocaine at 2 mg per kilogram in a dog can be given and repeated up to 2 more times for a maximum cumulative dose of 6 mg per kg in dogs, particularly if instability persists. If lidocaine is effective, the next step is to transition to a constant rate infusion, or CRI, typically starting at around 50 micrograms per kilogram per minute. In contrast, when canine patients are stable despite ventricular tachycardia, some cardiologists prefer to skip IV therapy and initiate oral medications such as sotalol. There is no consensus among veterinary cardiologists or criticalists on this issue, but I personally prefer starting with intravenous therapy in all patients with suspected ventricular tachycardia. But here's an important point. When you are presented with a canine patient that has a wide complex tachycardia, you can't 100% confirm ventricular tachycardia without a full 12-lead ECG. Although a 6-lead tracing is certainly more informative than a single lead, it is still less sensitive and more prone to misclassification compared with a complete 12-lead. The real strength of a 12-lead ECG is that it shows us the heart's rhythm from multiple angles. That broader view is what allows us to recognize the key patterns that help separate supraventricular tachycardia with aberrancy from true ventricular tachycardia. In SVT with aberrancy, the QRS complexes in lead V1 usually have an opposite polarity compared with the QRS complexes in the precordial leads V2 through V6, a finding we call precordial discordance. For example, on this ECG, the QRS complexes in V1 are negative, while the QRS complexes in leads V2 through V6 are positive. This precordial discordance is suggestive of supraventricular tachycardia with aberrancy rather than the true ventricular tachycardia. In contrast, on this other example, the QRS complexes in all of the precordial leads V1 through V6 are negative. In other words, they all point the same way, a pattern called precordial concordance, and this is highly suggestive of true ventricular tachycardia. Finally, note that there is also a fusion beat visible at the end of this tracing, which supports the presence of AV dissociation, another feature commonly seen in patients with ventricular tachycardia. Unfortunately, not all ER veterinarians will have access to a full 12-lead ECG. In practice, whenever you're faced with a wide, complex tachycardia, particularly when the ventricular rate is above 180 to 200 beats per minute, and especially if there are any signs of hemodynamic instability, it is safest to assume ventricular tachycardia rather than supraventricular tachycardia. Another finding on ECG worth mentioning is the R on T phenomenon, where an ectopic ventricular beat lands right on the top of the T wave of the previous beat. And that's the heart's most vulnerable period. This is associated with a high risk of degeneration into ventricular fibrillation, which is a cardiac arrest rhythm. In veterinary medicine, the evidence is less clear, and some cardiologists believe that RNT by itself does not justify treatment. But it's still something that gets attention when seen on ECG, and some clinicians will start treating it. In addition to confirming V-TACH on ECG, it is important to rule out systemic causes of V-TACH. These include electrolyte derangements such as hypokalemia, hypomagnesemia, or calcium abnormalities, as well as systemic crises like shock, cardiac tamponade, hemoabdomen, GDV, hypoxemia, or sepsis. These conditions are usually addressed during the initial resuscitation alongside antiarrhythmic therapy. A combination of exam findings, point of care ultrasound, and a venous blood gas with electrolyte panel will help exclude most of them. By the way, you can also enroll in a completely free, race-approved course on intravenous potassium supplementation by clicking the link in the description below. Of course, ventricular tachycardia can also be caused by structural heart disease, such as dilated cardiomyopathy or DCM, arrhythmogenic right ventricular cardiomyopathy or ARVC, myocarditis, endocarditis, and cardiac tumors. That's why echocardiography is indicated in most patients as soon as feasible, and in certain regions like Texas in the United States, you should also test for infections such as Chagas disease, or run a sensitive troponin I assay to look for myocarditis caused by another reason. All right, now let's go back to the treatment approach of ventricular tachycardia. If lidocaine boluses have failed, the second-line drug in most dogs is procainamide, a class 1A antiarrhythmic. The commonly cited dose is 10 mg per kilogram IV over 3 to 5 minutes, which can be repeated once to a maximum of 20 mg per kilogram in a dog. At the same time, you may consider magnesium sulfate. Although veterinary evidence is limited, magnesium salts are used in human medicine for certain ventricular arrhythmias, and there are reports of benefit in dogs as well. Before giving it, I like to confirm that the ionized or total magnesium level isn't elevated in my patient. If it's normal or low, I typically administer about 25 to 30 milligram per kilogram IV over 15 to 20 minutes. Remember, many magnesium formulations are highly concentrated and need to be diluted properly before administration through a peripheral catheter to avoid phlebitis. Dilutions and osmolarity calculations can be made much easier with the VetMCRUD calculator, available through the VetMCRUD Academy, and you can check it out by clicking the link in the description. If the patient responds to procainamide or magnesium, you can continue with the lidocaine or procainamide CRI. In practice, procainamide infusions are often cost prohibitive, so lidocaine CRIs are more commonly used. The next important goal is transitioning to oral therapy for long-term rhythm control. The mainstay drug is usually sotalol, a class 2 and 3 antiarrhythmic with beta blocking effects. It is typically started at around 2 mg per kilogram orally in dogs every 12 hours. Because sotalol takes 4 to 6 hours to reach full effect, you often need to continue the lidocaine CRI until it kicks in. If sotalol alone isn't enough, after you try to wean off lidocaine CRI, you can add mexiletine. Mexiletine is essentially an oral analog of lidocaine. It works in a very similar way by blocking sodium channels, but instead of being given intravenously like lidocaine, it can be administered by mouth for long-term rhythm control. But what if lidocaine, procainamide, and magnesium all fail? At that point, you're dealing with very refractory ventricular tachycardia. 2 additional drugs can be considered in this situation. The first is asmolol, a short-acting beta blocker. It should only be used with extreme caution. Its negative inotropic effects can be dangerous in dogs with pre-existing myocardial dysfunction and it's contraindicated in dogs in shock or severe congestive heart failure. Another option is amiodarone, a broad-spectrum antiarrhythmic with class 1 through 4 properties. It can be given orally or intravenously, depending on the formulation you have in your hospital and patient's stability. The most common side effects include hypersensitivity reactions, hepatic enzyme elevations, and GI intolerance. Another key point when managing refractory ventricular tachycardia is that increased adrenergic tone can actually worsen the arrhythmia. For example, if a patient is on dopamine or epinephrine CRI, it's best to reduce or discontinue them whenever possible if ventricular tachycardia is not responding to treatments. Finally, if all drugs fail, synchronized electrical cardioversion is the last option. Electrical cardioversion means delivering a controlled electrical shock synchronized to the R wave on the ECG. The goal is to depolarize a critical mass of myocardium all at once, putting the cells into a refractory state and allowing the sinus node to resume control. In human medicine, electrical cardioversion is used frequently. In veterinary medicine, it is reserved for refractory cases because of the need for general anesthesia and logistical challenges. General anesthesia is almost always required since shocks are painful and stressful unless the animal is already unconscious. Agents like etomidate are typically used for induction of general anesthesia in these animals. Standard defibrillators can be used in synchronized mode, which ensures the shock is delivered on the R wave rather than the T wave. This avoids delivering energy during the vulnerable repolarization period, which could otherwise trigger ventricular fibrillation. Initial energy is usually 1 to 2 joules per kilogram, with higher shocks given as needed. Most arrhythmias terminate with 1 or 2 shocks, although several may be required. Antiarrhythmic medications are often continued afterwards to reduce recurrence. All right, so to wrap it up, the evidence base for treating acute ventricular tachycardia in vet medicine is still limited. The choice of drugs and the order in which we use them depends a lot on what's available and on the clinician's experience and comfort level. Responses to these therapies can vary widely, and not all ventricular tachycardias behave the same way. When patients are stable despite V-TACH, some cardiologists even prefer to skip IV therapy altogether and start with oral sotalol, especially in breeds like boxers with ARVC. The bottom line is this: lidocaine failure does happen, and if you have a clear stepwise algorithm in mind, escalating through percainamide, magnesium, sotalol, and in rare cases azmolol and amiodarone, or synchronized cardioversion, you'll have a solid roadmap for managing one of the most challenging emergencies we face in critical care. I hope you enjoyed this video, and I will see you next time. Bye-bye.